So, good morning, everybody. It's a pleasure to welcome you all to the Complementary Integrated Medicine Consult Service Lecture Series. I'm Jack Killen. I am Deputy Director at NCAM, and I'm going to be taking this over from Patrick Mansky, who, as many of you know, left NCAM to go to Wisconsin a couple of months ago. It's a real pleasure today to introduce Dr. Margaret Chesney. Margaret, as many of you know, right now is professor in the Department of Medicine and associate director of the Center for Integrated Medicine at the University of Maryland Medical School. Prior to joining the faculty at the University of Maryland, Margaret held my job here at NCAM as deputy director, and she also served as director of our extramural division of research and training. The focus of Margaret's research over many years has been on the role of the individual in the promotion of personal health, prevention of disease, and the maintenance of optimal well-being across the lifespan. Much of her research has underscored the role that lifestyle and behavior can play in health, including work on the development and evaluation of behavioral strategies to enhance health and well-being in the face of serious health challenges from diseases such as cardiovascular disease and HIV and AIDS. And it's actually in that context where I first got to know Margaret, I don't know when, some time ago in the early 90s when we crossed paths a number of times in connection with her work then at the University of California, San Francisco's Center for AIDS Prevention Studies. Margaret's work has been widely recognized by awards from the American Psychological Association, the Academy of Behavioral Medicine, and the Centers for Disease Control. She's been president of the Academy of Behavioral Medicine Research, president of the American Psychosomatic Society, and president of the Division of Health Psychology of the APA. In 2001, she was elected to the Institute of Medicine. I'm not totally sure of all that she's going to be talking about, but those of us who know her do know very well that Margaret knows a lot about positive thinking and lives it. So it'll be a real treat to hear what she has to say today. Margaret, welcome back, welcome home.
Thank you so much, Jack. That's very kind. And it is good to be back. I think I'll pour myself some water. It's always a stress test to figure out how these work. And I want to welcome all of you and also thank Josie Briggs and those of you from NCAM who are joining us today. It's really a treat to see all of you. I've come a bit of a journey to be here, all the way from up in Baltimore. But I'd like to invite you on a journey, and during this journey I want to answer the question that I posed there. Thinking about mind-body interventions, is there power in positive thinking? And this is a question I hope that we can begin to ponder today and look over some of the literature in that field. Early medicine evolved as a search to eliminate disease in the individual. The early attempts were to repel spirits by shamans with rituals. There was also efforts to eliminate disease using potions and elixirs that were created by the alchemist. And the focus was always here on eliminating disease. We've gone from repelling disease and evil spirits to molecular medicine with an emphasis again on molecular malfunction. And I want you to notice that in both cases, the focus is on pathology, on sort of the negative in terms of thinking about disease, eliminating the negative. Many diseases were thought in ancient times to actually result from negative emotions, if you will. The mind, negative thoughts in the mind that somehow would produce bodily humors and fluids that would create disease, thinking back to Hippocrates' time. So the thought was that the mind had an influence on the body. And then it was in 1637 Descartes introduced his philosophy. I think, therefore I am. The mind is separate and works independently of the body, which was a very important introduction to having people then in medicine focus on the body, focus on anatomy and physiology. And in that focus and discovery that then has evolved over now centuries, there hasn't been as much effort and understanding or attention given to how the mind, the brain, and the body may interact. Medicine has increasingly focused on the body, if you will, that's really separate from the mind. And there's a view here as we think about the body where I think there's particularly a focus on structure. But some clinical practitioners continued over, particularly in the last century, to bring attention back to the emotions and how the mind or emotions could influence disease. And there's always the famous quote of Sir William Osler, who said, it's much more important to know what sort of patient has a disease than what sort of disease a patient has. Let's see, I need to move this here, excuse me. I didn't have a pocket, and they didn't have any way to put the mic on you if you didn't have a pocket. So I have to kind of remember where this item is. I'll have to remember pockets next time. There have been landmark developments that grow from the kinds of things that Osler was talking about. Franz Alexander argued, for example, that there were unconscious conflicts that might potentiate chronic conditions, such as hypertension. And he was actually one of the first scientists to study that, and out of that grew the American Psychosomatic Society, which started really as a small sort of salon of scientists and clinicians getting together. Hans Selye also introduced the concept of psychological stress, and here on the lower left-hand side you have some of the NIH program officers who are feeling a little bit of stress in recent months. There have been a considerable number of trials that have been funded by the National Institutes of Health that have focused on some of these concepts of how stress might be related to disease and whether or not one could reduce stress and by doing so reduce the incidence of disease. You probably remember some of the landmark work by Rosenman and Friedman, who identified the type A behavior pattern as being hard-driving, aggressive people who felt like they were always having to be time urgent, struggling against time, and they called that coronary prone behavior. And subsequent work by many people, and this is some of the work that I did when I first entered the field, was trying to understand what was it about this global behavior pattern that might be related to disease. And we looked very closely at the behavior pattern, and it highlighted issues of anger, hostility, depression, again, focusing all on negative emotions and how those might play a role in health. So throughout this, you see kind of an increasing attention over in the last few decades at the mind. And this, of course, is something that the public really resonates to. The mind is important, but again, the focus, even in this effort in mind-body medicine, or sometimes it's been called health psychology and so forth, has really been on negative emotions, on stress, depression, and sometimes considered anxiety, fears. And you see this here actually in mainstream medicine, that the focus, again, on pathology, at NIH, the focus in many of institutes is really mostly on the body and pathology. And this is not, I'm not criticizing this because I think it's extremely important. We should have a whole, if you will, and I will use the word hemisphere, a hemisphere of scientific effort in this domain. And you see National Cancer Institute focusing on the disease of cancer, diabetes and kidney diseases, NIAID looking at allergy and infectious diseases, all of which is incredibly important. But the question here that I'd just like to pose is, should we explore the other hemisphere? Today we'll be talking about positive emotion, positive health, and focusing, if you will, not so much on disease, but thinking about positive health. Is the positive hemisphere of emotional life worthy of increased attention? Might it generate important insights to enhance our treatments or help promote health or prevent disease? And that's what I'd like us to spend some time focusing on. But to do so, what I will eventually get to is looking at links between positive health and disease, positive health and well-being. But I'd like to start with something familiar, walk you through how the field of mind-body medicine linked to the mind, to the body, but actually in that negative domain, and then move us over to the positive to see if there are parallels. So let's start with the more familiar, and that was the studies of negative affect and disease. And then you have to sort of go, okay, what do we mean by negative affect? Here we have a couple variables that we focus on in this effort that people have engaged in. One is anger. Anger arises in situations that are perceived as unjust. Anger has physiological concomitants. Some of us have studied these in the laboratory. I was engaged in some research that showed that anger has more sustained effect on the physiology if the anger is not expressed, for example. So there's a lot of research trying to link anger to physical outcomes. There's also depression. We struggle for depression, definitions of these, but it tends to be in psychiatry viewed as produced by loss of support or reinforcement. It tends to be associated with diminished activity, and sometimes is thought as anger turned inward. And you can see violent acts that people engage in. Recently in Towson, a father seemed to engage in a very almost unspeakable act of harming his family, and people have looked at that to see whether or not he was depressed, what had happened to him, how could this be that he would engage in that kind of behavior. It was an anger-depression combination. So there's a great deal of research focusing on whether or not negative affect has effects on disease and disease outcomes, and I'll just highlight a few of these, and then we'll go back and look at the positive. And I tried to pick studies that are a little more interesting. We'll start with the religious orders study. There are 851 clergy, mostly men, average age 75, and they studied the relationship of mood states, suppressed anger and depression, and it was a longitudinal study looking over 4 years, and they found that suppressed anger and depression were associated with increased death rates in this population after controlling for the usual suspects. So there was one study showing that kind of a link. Others have found a link between depression and cardiac mortality. There have been many studies, I'm just picking one here by Penix, where they looked at 2,400 and some people who lived in the community, and they looked at depression. It was a prospective study of depression, and they found that those with major depression had almost double the mortality risk from cardiac disease. And this effect existed both in people, as you see on the left, who had no heart disease when they entered the study. And people, they scored them on depression, and you see the relationship between major depression in the yellow bars and the increased risk of cardiovascular mortality compared to people in pink, the pink bars, where there was no depression. And on the right is the association, people that had known coronary heart disease. So there's a rather striking relationship, and this is one of the studies that was looked at and is part of why the National Heart, Lung, and Blood Institute has engaged in some research to see whether or not, in one large trial, the ENRICH trial, studying, trying to understand, could we intervene, or the things that one could do to reduce the risk of heart disease. And that trial is still being analyzed. The initial findings were not positive, but there are a lot of sub-studies going on trying to disentangle what might be possible once we know that this prospective relationship exists. This is some data that just came out this March at the American Psychosomatic Society meeting by a young investigator, Tyndall, who did a secondary analysis of the well-known Women's Health Initiative. They had 107,000 women in the study, and a number of people who worked in working groups here at NIH had put some questionnaires in that study way at the beginning. And one of the questionnaires was an assessment of anger and hostility, or cynical hostility. It's called the Cook-Medley scale. So Tyndall did an analysis, looked at mortality in the in the Women's Health Initiative over a long period of time. They have now, I think it's like 11-year follow-up, and they showed that the people who had hostility at the beginning of the study, their greater number of deaths, though they're still small, 63 deaths per 10,000 in the least hostile group compared to 47, in the most hostile compared to 47 in the least hostile. And later, I'll give you the flip side of that, because there was also an optimism scale that was included in that study. And Tyndall reported on both of those. So then the question becomes, we've established that negative affect affects disease outcomes. What are the pathways? And I'm going to talk quickly about 3 pathways. One is physiological, one's maladaptive behavior, and I'll pick one aspect of aversive environments. What's a challenge here, and a challenge to this research, is that as you start to think about this, all of these pathways can be operating at the same time, which make it some of the difficulty in teasing out, what might be primary or how they interact. But let's look first at the physiological pathway. If a person is having a negative affect, how might it affect their physiology? And we know from research that Richard Davidson, I know he's spoken here at NIH a number of times, and most recently I think at the National Center for Complementary and Alternative Medicine. We know that there are negative affect is reflected in brain activity. There are reliable individual differences in electrophysiological measures. And Dr. Davidson's particularly been interested in the association that we find between negative affect and actually right frontal or right-sided activation in the frontal lobes. This is something that it's a landmark study that he's done, and he's gone one step further in his laboratory to then look at people who show this right-sided activation. And he's found that they have lower basal levels of NK, natural killer cell activity. They have greater decreases in NK function during a natural stress aspect of an exam. So their NK function, when you would want it to increase, is not increasing. They show less rise in NK function when people are exposed to a positive film, whereas others might show some rise, they show less. And they show lower antibody titers to an influenza vaccine. So he's trying to discern how might it be that people with this negative affect, which they've now traced into the brain, might have physiological factors that would impact disease. There's been, of course, we want to go in further and say what specific pathways might link negative emotion, in this case, to immune function. And the evidence suggests the HPA axis, and particularly findings in the area of cortisol. And I would just like to highlight that one of the people that's done some really innovative research in this area is Esther Sternberg, who's here at the National Institutes of Health and NIMH in the intramural program. So now we've got one pathway, the physiological responses. There's also problems in terms of maladaptive behaviors. And this makes the challenge in the research, because we find that people also have negative affect engage in a number of negative behaviors. Depressed people, depression is more associated with poor health behaviors, more alcohol use, sedentary behaviors. Something I had studied this when I first was working some with Jack Killen was adherence. People, when they get depressed, are less likely to adhere to care. And so that could be related to disease progression. Almost in a way, it's related to the negative affect, but it becomes another pathway, complicating some of the studies. In turn, these behaviors that I've just described, like alcohol use, cigarette smoking is another behavior linked to depression. These have adverse health outcomes, such as coronary heart disease. It makes it complicated, but it also starts to fill in what we see. Hostility. Remember, I've talked about depression, anger, these negative states. That hostility that they studied in the Women's Health Initiative, there's that same questionnaire happened to have been administered when young men were going to the University of North Carolina. It used to be an all-men's school. And so it made the possibility of going back to those records and using the alumni records to look at outcomes, health outcomes and health behaviors. And there's now a UNC alumni study that then takes these personality measures gathered when people were 18 years of age and looking to see what relates to outcome. And they found that hostility in the late teen years was associated with a number of negative health behaviors: smoking, excessive alcohol intake, and higher depression 30 years down the road. Another pathway, just to sort of fill out these 3 pathways I said I would talk about, is really something in the environment, adversive environments, and I want to focus just on one of those aspects, and that's social isolation. What is the problem with social isolation? Why is that an issue? let me return to the UNC alumni study. Gives you an opportunity to study people who are socially isolated. They have found that in that study, that hostility and also depression measured in those early years, in that entry, when people were filling out their application materials, they had to fill out this questionnaire. Probably doesn't fit HIPAA rules anymore, but that was how people sometimes do research, secondary analyses. It predicted social isolation 30 years later. And indeed, we do find that social isolation is associated with cardiovascular risk. In a recent study that Grant Hammer and Andrew Steptoe completed there at the University of London, they have been studying this Whitehall cohort. That, by the way, is one of the cohorts that led us to the whole area of health disparities, because it was Whitehall studies that showed the health disparities in civil servants working in England, and showed health disparities with the Queen at the top and people who were doing other jobs and who had better health and access to care and so forth. So it's a well-known study. Well, they've been looking at other things too. In 188 healthy men and 110 healthy women, they had a questionnaire called the Close Person Questionnaire, and this gave it a measure of how socially isolated. Did people have close friends, people that they could turn to if there was a problem? And they found that socially isolated men and women had higher levels of cortisol upon awakening and throughout the day. You'll remember the cortisol from the earlier slide being suspected as an important mediator, if you will, or mechanism by which negative affect may have its effects. There's also a well-known study that was done by Redford Williams. This is some years ago, where this is also in North Carolina. They studied over 1,100 men, 245 women who had heart disease, and they looked at them over a 5-year period of time, and they were actually looking for other risk factors like lipid levels and so forth, and they had this one item kind of buried in one of the baseline questionnaires, that they had marital status, and they also asked people if they had a confidant, someone that they could turn to. And what they found was that people who were unmarried and did not have a confidant, they had no one that they could turn to, had threefold the risk of death compared to those that were married and with a confidant. And I know Redford Williams, I talked to him and I said, did you control for the fact that maybe a person was, had a heart attack at home and was there someone there? But they did look at the conditions under which people had a heart attack, so they had controlled for that. So there appears to be some adverse consequences here. It is really striking, too, that people who most need social support tend to be those who are the most isolated, which is unfortunate. And you see that, too, as we talk about positive affect. Positive affect seems to draw social support, whereas negative affect, when people really need others, those people are people who lack that in their environments. So now I want to shift from this familiar world to begin to do this answering this question. Are there pathways by which positive states somehow influence health and well-being? So now we have to think about, how do you define positive states? And this gets a little complicated. This is an area, we're sort of charting new territory here. Carol Riff has done some of the nicest work to sort of sort out what it is we're talking about. What should this domain be? And she has separated out hedonic measures, like just being happy or having a lot of life satisfaction, a positive emotion, from eudaimonic concepts of well-being that include fulfilling a process of self-actualization or psychological well-being. And then she has, and I should say too, that there's little consensus in the field about a single definition of positive affect. This is really new, and the measures of this are all relatively new too, which makes it more difficult to study it. We don't have as many questionnaires that were given years and years ago at the University of North Carolina that were validated questionnaires of positive affect. I'd like to focus some in the rest of my talk on, though, this concept of psychological well-being, but you'll catch me. I'll have data looking at positive affect here, psychological well-being, because I'm trying to sort of draw from this, because this hemisphere of positive emotional states is not well charted. In Riff, I'd mentioned that she's done a really exceptional job, in highlighting these areas now within psychological well-being. you actually see that she's come up with 6 categories there: environmental mastery, personal growth, purpose in life. I want to mention something here that I think is important, though, and that's that some of this work is really culturally specific. This has really a kind of this research is being done mostly in North America and in Western Europe, and we may need to be cautious as we go to other cultures. But in a moment, I'll share with you some results from around the world suggesting that positive affect does indeed seem to carry around the globe. I'm going to be talking in a particular area of interest that I have on personal growth, a dimension of psychological well-being, as I go through this, but you will catch me. I'm going to use bits of data from different domains within positive emotions in order to make a possible case that there is some evidence that just as negative affect had effects on the body, positive affects can affect longevity and maybe well-being. We did a religious order study. We should turn to the nun study. You think all I have are religious things, but I think this one is particularly interesting. This was a study of 180 nuns that Danner did. These nuns had written autobiographical statements when they entered the convent way back when they were teenagers, and they were, when they were 22. And then they were scored for their emotional content, and then Danner looked to see what would predict survival 6 decades later. And what Danner found was that there was a strong relationship, the most significant relationship, where people who had entered the convent not with sort of negative feelings of guilt and needing to go to the convent to work through struggles, but people who entered it with really a positive outlook on life, made positive statements about why they were making this personal choice, and it predicted survival 6 decades in the future. And what he wrote in his discussion, his seminal paper, was that finding such a strong association of written positive emotional expression to longevity indicates a need for research that shed light on the underlying mechanisms and mediators that were responsible and associated with this relationship. And that's what I'd like to try to do this morning. But let me share with you, it's not just nuns. Another study, and I've just picked some. Oster did a study with senior Mexican Americans. It was just a prospective study of 2 years. And this one's important because they had measures of both positive and negative affect. And just very quickly, they controlled for functional status, socioeconomic status, BMI, etc., and found that positive affect at baseline predicted survival, even when they controlled for negative affect, which is a hint of something to come, that these are not opposite ends of a continuum. I mentioned that I would share with you the Women's Health Initiative finding that Tyndall reported last March. Using a different scale, optimists, this is the life orientation tester, it's also known as the optimism scale. Optimists had fewer deaths per 10,000 compared to pessimists, and this was controlling for the other factors. So there's a hint from that study as well, secondary analyses. Well, there have been now enough studies of this that Steptoe and Chida in their laboratories in England pulled together the prospective studies that had mortality as an endpoint. They found 35 studies in healthy populations and actually 35 studies in diseased populations, and confirmed, though it's not a strong hazard ratio, a significant relationship in these studies across them in terms of an association with reduced mortality, suggesting that there might be something there. And so now what I'd like to do is, having established there may be an association, let's look to see whether or not the same pathways may be operating. As we talked about before, what might be the channels by which positive affect is associated with longevity. So we can start again, going back to some research that Richard Davidson has done. Just as he had found that negative affect was associated with right-sided activation in the frontal lobes, the positive affect is associated with left-sided activation. And there again, they've been able to then say, okay, people who are showing this activation, this greater electrophysiological activity in the left frontal lobes, what is that associated with? And here he finds the inverse. Larger increases of NK function in response to the positive film clips, and larger increases in antibody titers to influenza vaccine by one of his colleagues. So we seem to be finding in this case, some same physiological pathways but operating in a different direction. Others have looked at this positive affect immune function domain. One study took faculty through the course of the academic year and measured them in positive affect and then just counted up the number of colds they had and found that there was a significant relationship, fewer colds if you have positive affect. Maybe they're more likely to wash their hands. I mean, there may be some behaviors associated with this, or wear masks. I thought I might come here today and have everyone wearing masks, and I'm pleased to see that we're not at that point yet. One of the, I think, most clever colleagues that I have is Sheldon Cohen. He has done studies where they put people in a controlled environment, they assess them carefully, and then they expose them to rhinovirus. So they have control over the point in time when a person gets infected. And he found in his research, he did find that perceived stress and life events are associated with increased likelihood on the negative side, but he's also then went back to his data, pulled out some items that were associated with positive emotional style, and found that those people were at lower risk of contracting a cold even following a viral challenge. There have been some other studies. A group in London looked at people, and they actually were studying 59 healthy male students. This was a recent study, just came out. I wanted to include some very recent work. And they found that the students had a higher level of optimism, had actual smaller IL-6 responses to a stress test. And as you know, IL-6 plays a pivotal role in inflammation and immunity. Circulating IL-6 is elevated in cardiovascular disease, or arthritis, and so forth. So it's something you don't want to have elevated, and these optimistic people had actually lower levels. Also in England, again with that Whitehall study I described, Steptoe and others had people rate they were worried about just using these global measures of, I'm a happy person. So they actually had people stop and rate their mood states periodically through the day. This is called ecological momentary assessment. And they just rated on a scale of 1 to 5 how they were feeling at that moment. Like today's kind of a dreary day, it's raining, and some of us sort of go, oh, it's raining, singing in the rain. Others of us, it's like, oh, this is a pain. So they would have people rate this, and they found that happiness in this cohort was associated with lower cortisol output over the day, lower ambulatory heart rates, and lower plasma fibrinogen levels in response to stress. So we're starting to get some indications of what might be mechanisms by which positive affect is associated with longevity. But these are like glints in the sand, because each of these studies is using different types of measures. It's just I'm trying to give you a sense that there might be something there. What about health behavior? Well, we find out that people with higher life satisfaction, again, remember I'm plucking from that whole list of ways this is assessed, they tend to engage in more health-promoting behaviors. Physical activity, they're less likely to smoke, they're less likely to, they have a lower alcohol intake, they have a healthier diet. You can see now why it gets tricky to do these studies, because you not only are looking at physiological pathways, but you have people that are engaging in a whole different set of behaviors that make it a real challenge. And I just want to touch on this other domain, the social support, that I mentioned before, and share with you findings there. It turns out, as I hinted at earlier, that people who report positive emotions receive more social support. Just, it's wonderful to get it, but we need to share that social support with others as well. And the positive affect is associated with the number of people who provided help to others in a 12-month period, and this was a study done by Eckenrode. So you see now I've made this association. We know that there are pathways by which positive emotions influence health and well-being. I'd like to underscore something that the research is suggesting. It's very important that positive emotions are not the inverse of negative emotions. And this was discovered by a number of people over the last couple decades or so, that under chronic stress, it's expected that many of us will report high levels of negative affect. And I know that some of you are having a lot of stress now with the stimulus package. Those of you who are working at the Institute, there's just a lot to do. It's a good problem to have, but it can be very stressful. And in some ways, that encapsulates what I'm talking about. It's a good problem to have additional funds to fund great research, but unfortunately, it came packaged with all of these demands, strings attached, and the work has to be done in a certain time frame. So it shows you can have both of these emotions at the same time. Well, the same occurs in studies that when people are under high levels of emotional stress, you can see when you assess them that they'll be showing negative and positive affect at the same time. Susan Folkman, I think, articulated this very well. She, and I was actually working with her on this study. We were studying the caregivers of persons with HIV/AIDS. And in that study, sometimes the caregivers had HIV/AIDS themselves, and we also had a group that didn't have HIV/AIDS, but they were both caring for someone, and this was before we had antiviral therapy, so we knew that the person they were caring for was very likely to die during the course of the 5-year study. And so we could do a prospective study of caregiving stress and bereavement. And what we found was that positive affect and finding personal meaning in the course of those early months or years when we were studying people when they were caregiving, if they found meaning in that, they had more rapid recovery after bereavement, but they would become very bereaved at the loss of their partner. And this is work done in San Francisco. When their partners would die, it was devastating to everyone. But even in that moment, as we would be assessing and interviewing them, people who had this positive construct in their lives could find things that they had noticed. Like in the middle of an interview, they might look out the window and say, "Oh, you've got to look, there's the most beautiful sunset. I feel like Tim is there." And that they could do that was really striking, and we've written some articles about that. That positive and negative affect coexist is also coming from the study that Pressman just reported March of this year, where she worked with the Gallup organization and did study people around the world, and that studying the association of affect and physical health, and she found that negative affect was associated with perceptions of health, negative perceptions, and that positive affect was associated with health, positive perceptions of health, and that these associations were independently related to health. They were not opposite ends of a continuum. So a person you could have both of those in the research that she did. How is it that positive emotions could have this effect? This is just, sort of thinking about that. We've talked about the physiology and so forth. Carol Riff and Barbara Fredrickson have written on this. And so I've sort of caught what I think they're trying to say, that it may be that these are distinct emotions and that positive affect may, according to Fredrickson in particular, creates a broadening and building capacity for coping with stress. Because the positive emotions in her writings, she sees evidence that people have a broader attention. It broadens the scope of cognition, of thinking of possible solutions, and it broadens the scope of actions that people can take. And she has a whole theory called broaden and build. This then, just sort of moving into this hemisphere, and again, we're like pioneers and we're picking up evidence as we go. I wouldn't say this is nearly of the stature of the other science that I've shared, or the stature of what we know about the body. But can positive emotional states be increased? That becomes sort of interesting, particularly if you tend to be more of a negative person. You want to know, is there something I can do about this? And enhancing positive states is at the core of some of our most commonly practiced mind-body strategies, like mindfulness. And there's been very little work on this in the area of mind-body medicine and mindfulness. I'll share the one study that I found where people had this, there's really been a movement, if you will, of people getting interested in mindfulness-based stress reduction, MBSR. And one study took 60 people who were depressed. They enrolled in an MBSR class that's 8 sessions, and there's an all-day retreat. And embedded in this mindfulness-based stress reduction that was developed by Jon Kabat-Zinn, sort of based on some of the Buddhist and Zen philosophies, but it's sort of stripped of those and really focuses on stress management. And there is a cognitive aspect that's embedded in the latter sessions when people are learning to meditate. It focuses on reducing distress and enhancing well-being. it directly tries to do that. And in this study, Niklicek and I'm probably not saying the name right, they randomized people to MBSR versus a waiting list, which is not the optimal control. You'd rather have an active control. But in a pre-post study, and you'd like to have a follow-up, they showed that MBSR was associated with decreases in perceived stress, which is the negative side, but they also saw increases in positive affect. There are a lot of studies showing that it reduces distress, but this is one that showed the positive affect. If we broaden and look at some of the cognitive stress management programs that have been studied in the recent decades, there's work by Mary Carlson more recently on combining positive affect and self-affirmation interventions, and she's just reported on some of those findings just in the last month, showing that one can affect positive emotion. There's been this cognitive stress, behavioral stress management work that Michael Antoni and others have done at Miami. And I'll share with you some of the work that I did before I came to NIH and served as deputy director. And Jack's is holding that job now, in what we called coping effectiveness training. And I need to preface this work that I did by saying that I had been doing behavioral interventions with various health outcomes in chronic illness. I was looking at behavioral interventions to see if one could affect heart disease, hypertension, and so forth, and was really discouraged that we would carry out these interventions, we would see some modest effects, but it wasn't that good. And we started with progressive muscle relaxation training. So then we started adding things. Well, people said, well, you should have some problem solving. Well, you should add autogenic training. Well, we should add this and that. So we expanded these. And you'll see, if you look up stress management interventions, they teach people a sort of laundry list of tools, of different strategies. And we were getting effects, and we were getting published, and it was significant, and we would see actually biological effects, but it wasn't that strong, wasn't that enduring. So I went back to basic behavioral science, which is there's an area of basic science in sort of how people think and how they engage in behavior, how they make decisions. And this is when I met Susan Folkman. And I talked to her. I went and talked to her about stress and coping theory. And she talked with me about the work that she had done on stress and coping theory. And here I'll share with you her thinking. And she had been working with Lazarus on this. How do people cope with stress? So it was not clinically oriented in a way of intervention, but just sort of descriptive. And she talked about how people face a general stressor, and you think in your life, many of us face general stressors. Sometimes you might even say, I feel really stressed. What's going on? You know, why do I feel this way? And then you start to think about, what is it that's bothering me? And then here was something that Lazarus and Folkman, and subsequently Susan Folkman, carried further, was you need to separate stress, that there are changeable aspects of stress and unchangeable aspects of stress. So that, for example, a person with HIV disease, there's a lot of the stress in their lives that might be changeable. Who do they tell? You know, should I tell someone? I'm keeping a secret. That's something you make a decision about, and that can be changed. Life insurance and medical insurance companies were significant stressors for people who had HIV/AIDS. Those are things one can do something about. Sometimes it's a struggle, but there's opportunities. Then there are unchangeable aspects, like one is infected with HIV/AIDS. That's not changeable. An unchangeable stressor for someone my age is that I'm aging. My body is changing. I can do some things about that, but the basic fact is there. And I'm reminded of that periodically as I go up and down stairs and my knees make this funny noise. It sounds like they're making ice or something in there. That's sort of unchangeable. I'm watching the NKIM website to see what can I do about this. I'm not ready for knee replacement yet, but it's unchangeable at this point, except that I keep noticing I've been reading up on various things I might do. But aging is unchangeable. So what Susan highlighted that was, and this is work she's done really over decades with Arnold Lazarus, is that if something is changeable, that's where you do problem focused. You focus on changing the problem. And if then there's something unchangeable, like HIV/AIDS, which is distressing, you attack the emotion. And and then I immediately said, oh my goodness, what had we been doing in stress management? supposed to be a pointer here. Let me see. I'm not very good at these things always. It's a stressor to use pointers. But I had pushed all of these together and said, deal with your stress. Figure it out. So I turned to Susan, and well, Susan went on. She said, let me show you something. And she showed me data. Again, this was descriptive data that she had done, where she looked at people who had tried emotion-focused strategies when they could make a change, and they had greater symptoms. This is not good, and in fact, it has adverse effects. And I'm sitting there going, oh my, I'm thinking about the data. And then she pointed out that if something is unchangeable, there you want to bring problem-focused strategies. If you bring problem-focused strategies to an unchangeable event, there are greater symptoms. And Andrew Baum, funded by NIMH, did an incredible study on 3 Mile Island. Most of you are too young to remember that. But that was essentially a nuclear accident. It happened. It could not be changed. And he showed that people who were trying problem-focused strategies after the fact were more likely to become ill. So you've got to align everything just so. And that's when I said, Susan, have you ever thought about intervening on this? And she goes, oh, I don't do that. And I said, why don't we do it together? And so then we worked together for about 10 years on coping interventions to try to teach people about this. And we also brought in social support, because it turns out that when we go for social support, if something is unchangeable, or say you really want help with your emotions, you want to go to someone where you can say, I just need to vent. And it turns out people have sort of a strong suit. So some people are problem solvers. So when you go to them and you just want to vent and complain and be upset, they want to solve your problem. And so they'll say, well, let me tell you what to do. And you go, no, 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 that's not what I want. And so we taught people that what you should do is, when you're feeling stressed, think about who you really want to get support from. What kind of support do you want? Do you want your problem solved, or do you just want someone to go walk with you and talk it through and be able to just vent? And we found actually in some of our studies, some marital problems were associated because people would go to the same person all the time, wanting that person to somehow guess. And actually my husband is like that. I like sometimes to vent and just complain. And he wants to solve it. So he's just, now what he does is he says, now can I tell you what to do? And this is not good. So I've learned, don't go there unless I want a solution. And then I do. So we developed coping effectiveness training and ran a number of trials on this, with focusing on persons with HIV/AIDS because they had unchangeable stressors. And here you see we had emotion-focused coping. We taught people to make this distinction. And so if they were trying to deal with their emotions, they would look at relaxation training, guided imagery, types of meditation, like autogenic training. If something was a problem to be solved, we taught them negotiation skills. We taught them to negotiate with insurance companies and how to communicate more effectively. And we also, over the course of this work, enhanced our intervention and added in a component to enhance positive affect. And I have to tell you, the reason that both Dr. Folkman and I started focusing on positive affect wasn't because we thought of it. It was the persons with AIDS that came to us and got angry with us and vented about our questionnaires. They said, ever since I've had HIV, I have lived my life with this sense of purpose, and I don't want to waste a minute. I don't miss a sunset, and you don't ask me anything about that. You never asked about that. And we actually looked and we found a few items here and there, and that's how Susan and I started working on it. And then in the intervention, we really expanded this. And so I started to say, how do you enhance well-being? And I went to the psychiatric literature. There was practically nothing there. It's all about getting rid of negative affect. But there are hints. So we actually scoured the literature and pulled together, pilot-tested, focus grouped an intervention where we had people in our intervention increase awareness of, become more aware, acknowledge, and then in the groups, share positive experiences, share them with one another. Like I just met someone this morning who just did a 50-mile run, walk, trek experience all in one day. Some people run, some walk, and it was a positive experience. So he shared that with me and made me feel good. We can all go out and sing in the rain. Well, maybe not. When you're facing unchangeable stress, look for lessons learned, identify the positive moments, reframe some of these events with acceptance, compassion, forgiveness. Use humor. We embedded humor throughout our manuals. Most manuals for interventions are boring. Well, we put cartoons in them. And then it was interesting. People start bringing cartoons to the group. We never said bring cartoons, but they did. Here's some of the most important. This we did find in the literature. Positive accounting at the end of the day. Keep track of things that go right. Most of us at the end of the day, we go, oh, we just didn't get anything done today. This is terrible. No. What did you get done? And actually notice when things go well. And I'll share you quickly one thing that I do that's like that. You know, have you ever noticed that you only notice you have a flat tire when you want to drive the car? This is sort of a thing for me. And I seem to get flat tires. I don't know about you, but I get them, and I'm not really good at doing the whole changing thing. And so I notice every time I go out to my car, if the tire's inflated, it's a great day. And so after I'm finished with this, I'm going to go out to my car and I'm going to go, yes, yes, this is important. This is good. It's a good thing. When you get the mail, nothing from the IRS, it's a great day. You have to notice when things are going well. And most of us don't do that. We taught people to do that, and they bring in jokes of things they noticed. Identify sources of positive meaning in life. We embedded that in the interventions too. We had people talk about their values, their goals, their purpose. People sometimes were very ill. They knew they wanted to go to medical school, and particularly in our early studies, they knew they wouldn't make it. And so we talked about what was the underlying goal. They wanted to help people. So they got very involved in things like Meals on Wheels. Some of them worked in hospice. They wanted to help people. We found ways to meet that underlying goal that was so important. And let me just share with you, can we increase this state? Well, this is just one of our trials. We randomly assigned HIV-positive men to various forms of coping effectiveness training with extended, and we tried different types of follow-up groups, and then we had a minimal contact control. We earlier had a health education control, but it made people worse, and the IRB wouldn't let us use it. We gave people all the information they needed to know now that they had HIV/AIDS, you know, like you would normally do, pamphlets and psychoeducational material in groups, and the people became incredibly overwhelmed and stressed. And so the IRB said you can't use that control anymore. So we did a minimal contact by phone. And basically, we needed now a way to measure this. How do you measure positive states? We found a scale that Crystal Parks had developed. She was a postdoc with Dr. Folkman and myself. And she worked on this scale, and it had items like, I learned to be myself and not try to be what others want me to be. I learned to be open to new information and ideas. I learned to find more meaning in life. We wanted to change items on that scale. And so we pulled together a sample of persons with HIV. They'd had HIV for 8 years. They were relatively ill with the disease, many on medications. I'm just going to share with you the results that we had. Here's the pre to post. There was a 3-month intervention. And in the coping groups, we got an increase in self-efficacy, a coping self-efficacy measure. But we also impact positive states of mind, a very short scale that has been in psychiatry for many years, developed by Marty Horowitz. And we also measured that personal growth scale, and we saw a significant increase in personal growth, suggesting to us that indeed positive emotional states can be increased. But then the question is, can they be maintained over time? And just to share with you quickly what we found, we followed people for an additional 9 months. And unlike intervening on depression and some of the negative states that I'd done earlier, we would get an initial response that was significant, and then over time it would fade. As people engage with the stress of daily life, some of our interventions for depression, anger, anxiety fade with time. But this, it was striking to me, was how efficacy was continued. And just share with you positive states of mind. Also, you see the CET groups here in yellow. The blue group is the minimal contact control. It increases somewhat from getting these phone calls, but not like the groups that were in CET. And the effects were sustained. Personal growth, again, had its biggest peak right after therapy, slipped a little, and then over time it continued. And really seems to be holding, which made us wonder, what is sustaining this? Is it partly that maybe as people are being more positive, they're getting more of that social support? We don't know. That's something that would need to be discovered. But it gave us some sense of, if you will, hope that maybe there's something here. So what I've done today is I've talked about the pathways by which positive emotional states influence health and well-being. I've talked about how positive and negative are not opposite ends of a continuum. These seem to be independent. Can positive emotional states be increased? Yes. Is the effect maintained? Yes. And you could say, okay, so what? You know, is there some kind of opportunity here? And let me just, I've always been someone who kind of wants to sort of think ahead. When we think of healthcare, we tend to think of two lines. There's being healthy and not being, which I put green like mucus because I just had this really bad cold when I was doing this slide. We have ill health. And most of our interventions here at NIH, University of Maryland, and elsewhere, most of our interventions are really designed to get people back to neutral, to get them back to that state of health. And what I just want to posit is maybe there's a potential that we could design, and we're really in the design mode here. Could we design mind-body interventions, positive interventions, working on positive emotion that might take people beyond that point and give them some resilience or reduced vulnerability to the perceived daily stresses that go on, like the fact that some of you came here through the rain and you have to go back through the rain, or the other daily stresses. Can we do more? Might new mind-body interventions pull us beyond the state of sort of not being ill to something greater? And it just makes me wonder, should we broaden our agenda to include optimal health and begin to explore the other hemisphere? Because I think in mind-body medicine, we have a choice. We could continue focusing on treating disease, and we should. It's very important. It's something I'm committed to for the rest of my active life. And you can say we can focus only on the weeds in the garden, understanding how those weeds take root, studying the impact on the soil. Or can we plant a few flowers, understand how they take root, and help them grow? Thank you very much. I don't know if I think we're just about at time, but I can stay and answer a few questions if that's possible.
Yeah, that's great. I also forgot to mention that we have a webcast audience, so there's others out there listening, but that's a couple of questions, I think.
Yes.
Hi, Margaret. That was wonderful, and I think I saw you at the Institute of Medicine, had an integrative medicine conference earlier this year, and clearly you're part of the vanguard of what's going to be happening, I think, nationally once that report comes out. I had a question about what are the implications for training us health professionals from this? I just wonder if we could broaden even more from just patients and thinking about our interactions and ourselves somehow becoming more positive, both in our training programs and in our clinical interactions.
I think it's a wonderful idea. It's something that we should consider and embrace. And in fact, for me, because I'm so interested in the science, I think that's a great place to start. And I'll say, too, that in medical research, it is often our patients that actually educate us. And so I think that this is something that we should explore. I think in some of the academic programs that NCAM helped foster, what is actually occurring, like here at Georgetown, is a whole program where medical students are initiated into mind-body classes where they actually learn how to do meditation, and they get opportunities. Aviad Haramati has a wonderful program at Georgetown where they actually have opportunities to learn this, and it's part of a course on learning how to interact with patients differently. And the University of Maryland, we're now starting that. So I think in medical school, there's opportunities for that, so that we can explore some of this experientially as well. I don't think, we talk about do no harm. I don't see much harm in exploring that aspects for our students and for ourselves. And it might do some benefit. Any other thoughts or comments? Well, thank you so very much for coming. I'll stay here for people who want to have comments just one-to-one. And it's great to see some friends.
Next month, Dr. Richard Nahan of NCHEM will be presenting some very latest information from the National Health Interview Survey on CAM in the United States, CAM use. So we look forward to seeing you then. Yes, that'll be on June 1st, right here, same place, same time.
And in fact, of course,